it stands. So I'm going to probably, I don't know how much time I have. Maybe I have 20, 25 minutes, Dr. G. Vijay Kumar. I might exceed my time maybe by 5 or 7 minutes. And, COVID changes every day. So some of the things which I say today may not hold appropriate later. And I'm just trying to negotiate my slides and I'm not able to do that. So anyway, so what I speak today on COVID-19 and diabetes is on 22nd November 2020. And that's something which we all know we need to speak on and we need to be there. And let's look at, we know that number one and number two for morbidity and mortality of COVID is clearly diabetes and obesity. And diabetes and COVID has a link. We know that there is very good epidemiological evidence to suggest that there is an association of diabetes with other infectious diseases. So we know that from that data. We know the rule of 10, that 10% of diabetics get tuberculosis, 10% of tuberculosis patients will have IgT or diabetes. So we have very good data, whether it's fungal infections, urinary tract infections, respiratory infections. Diabetics are more vulnerable to get infections in general because of a lower immune system. We also know, that is the second point, that in the bacteremic form of pneumonia, it's an independent risk factor for LRTI. And we also know that when it comes to serious infections in hospital setups, which is something which we all recognize better and we know better, clearly we know that 6% of infections related to hospitals and 12% of infections related to hospitals are linked to type 1 and type 2 diabetes. So that's something which we know very clearly. And then we got this large Chinese database to show very clearly that, hypertension was number one, diabetes was number two, and obesity was number three. And that is what they showed: obesity, hypertension, and diabetes as a deadly trio. And this so-called trio clearly had data to show that diabetes and COVID was strongly linked. So what do we know today? What we know today about COVID and diabetes is people with diabetes have increased risk of infection because of innate immune defects, which is linked to elevated glucose. Both acute hyperglycemia and chronic hyperglycemia leads to blunting of innate immune system. The second fact which we know about diabetes is that when you have a diabetes state, it's a pro-inflammatory cytokine state, which means a normal diabetic also has exaggerated IL-1, IL-6 and TNF-alpha. The third point we know about diabetes physiologically is there is increased expression of H2 in diabetics. And the fourth thing which we know about diabetics is diabetics in general are more pro-coagulable, or they have increased coagulation activity and hypercoagulable. So obviously they have stickier blood, they have more coagulopathy, they have a lot of H2 expression, they have a lot of pro-inflammatory cytokines, and obviously they have a blunted innate immunity. That's what we know as of today. Clearly we know that the H2 has been linked as the docking receptor for COVID. COVID docks in our human body through the H2 pathway. Clearly that's now very well recognized. And when it docks on the H2 receptor, it triggers a serine protease called TMP-RSS2, which is a transmembrane serine protease. And that will trigger the entry of the viral particle through furin inside every cell of our body. First being the lungs, second being the cardiac tissue, third being the renal tissue, fourth being the enterocytes, and fifth being pancreas. And there's very good data now, including human data, to show that lung is top on the pecking order, followed by probably the gut. Heart and kidney and pancreas are right up on the pecking order. So obviously H2 has a role. Clearly we now know that when we explore through various analysis, including a Mendelian random analysis, there is a direct expression of, on a GWAS in type 2 diabetes, on ACE expression. So we now know that when you look at a putative receptor of SARS-CoV-2, which is ACE2, clearly there is an increased expression in type 2 diabetics. So obviously, when you look at susceptibility to COVID and the predilection of COVID to develop severe complications, including a cytokine storm, including myocarditis, sudden death, ARDS, clearly it is all linked to various factors. Whether the SARS-CoV-2 will have an impaired neutrophilic response, which is seen in diabetics, whether it is linked to impaired interferons made by the natural killer cells, whether it is the improper antigen presentation by the dendritic cells or the CD4 cells, whether it is the impaired macrophage function, or whether it is the increased ACE2 expression. All these features which are listed on the slide are seen in diabetics. And therefore, diabetic presents a perfect culture medium for not only COVID infection, but more important than that is it prevents a perfect milieu for a COVID storm. And that's what COVID does. So obviously COVID fundamentally has this big challenge. We also know that a lot of these conditions can destroy islets, because we know islets of Langerhans, as we celebrate a century of insulin discovery, have H2 receptor. And obviously, there is a ketosis prone flat blush diabetes described in COVID. So we also have an entity, distinct entity. You may not be diabetic, you may not have a predisposition to get diabetes, you may never had family history of diabetes, yet you will see a patient standing up in the hospital with frank COVID, moderate to severe, and you will get flat blush decay, frank decay. I've had an elderly patient right in the beginning of the pandemic, somewhere in the month of 4th of April. I got a senior citizen, 89 years old, glucose 555, never was a diabetic in his lifetime, never, and had mild TSH elevation for which I had not treated him, had no family history of diabetes at 89, and was in frank diabetic ketoacidosis, not even a hyperosmolar state, had a flat blush or a flash diabetes. This was a ketosis prone diabetes and probably had a COVID pancreatopathy. So obviously there is data to show that, and that could lead to death. And that's why we know diabetics are up on the pecking order, and glucose predicts mortality. This is Bruce Board's study, which very clearly showed in the US hospitals, 88 US hospitals, they analyzed that people who had no diabetes, no hyperglycemia, mortality was 6.2%. Minute they had diabetes or high glucose, mortality was 28.8%. So clear data to show that glucose matters and it increases mortality by fourfold. There's a direct endocrine link, as I told you. The link pathway is the MAS receptor pathway. And Stefan Borenstein showed this so nicely that the MAS receptor pathway is mainly linked to the angiotensin 1-7. This will lead to an anti-inflammatory, anti-fibrotic response, which allows recovery. And what happens? What happens is that in severe COVID and diabetes, there is the activation of these pathways, increase activation from 81 receptor to 82 receptor. And that switch which occurs actually is a very negative switch. And that negative endocrine switch actually makes things worse. Also, there's very good data which Bruce Board published this year to show that acute hyperglycemia is linked to COVID mortality. And just simple hyperglycemia can kill. So obviously diabetes has evidence to show that it will have more severe COVID, and that's something which we know. And let's summarize that high glucose predisposes to enhanced release of cytokines. There's greatly elevated levels of inflammatory cytokines leading to multi-organ failure. There's a metabolic inflammation. There's a compromised immune system which leads to impaired healing. And clearly we know there's dysglycemia and immune dysfunction. So diabetes, clearly IDF also stated this, that is a functional immunocompromised state, and it promotes, high glucose promotes viral replication. So obviously diabetes is a high risk for COVID-19 infection, and we all know this. We had developed an Indian COVID score. Any person above 55, male, gender, hypertension, diabetes, obesity, chronic heart disease, COPD, chronic kidney disease, any congenital or acquired immunodeficient state, any human being using steroid, immunosuppressant or transplant recipients are vulnerable for COVID in India. The 65 cut point may not be applicable. Our cut point is a little earlier. Male, gender, hypertension, diabetes is so vulnerable. So let us look at management priorities of COVID with diabetes. Well, obviously, we need to see the collateral damage. What happens with the change of care. And we know that staying healthy and controlling diabetes during pandemic has been a big challenge for all of us as physicians at large. And we know that various authorities said that we need to get better care for diabetes. We need to tell people with diabetes that they need to maintain a healthy diet, monitor their glucose, ensure that they keep connected with doctors, take their injections and tablets on time, do their distancing right, and ensure that they are a vulnerable group. So the outpatient care needs to be digitally connected. We need to sensitize diabetic patients, reach out to them, and we should ensure that they don't discontinue their therapy and do telehealth and telemedicine, and try to keep normoglycemia, A1C to target, and sometimes even use a CGM-like mechanisms. Because any minor fluctuation in high blood glucose level will make them relapse, vulnerable to infection, not just COVID, but even non-COVID infections. And therefore, it's important that they seek help and treat and care and be very, very aggressive about it. So obviously, diabetic patients with COVID, we need to have a step-by-step approach. We need to get aggressive. We need to ensure that they are volume depleted. We need to ensure that they are appropriately isolated and they take the right amount of oral anti-diabetic drugs. If they get COVID with diabetes, we need to do and tell them simple sick day rules. We need to educate them in advance that if they get sick, get their glucose on target, take their medications on time, upgrade it. If they get thirst or dry mouth, if they have a lot of polyuria, if they feel tired or weight loss, they need to report to the doctor or get into hospital. That's what we need to do. So obviously, glycemic management of COVID with affected with diabetes, we need to know are crucial for a tight glycemic control, and that's a standard of care. So obviously, what are the treatment pathways? Because are there treatments of diabetes which could be anti-COVID? Are there treatments of COVID which might aid and help COVID? Or could they be deleterious in COVID? Let us look at that. Well, clearly we know all diabetics will see fluctuations or worsening of glycemia. All diabetics will need sick day rule management, and we recommend close monitoring of blood glucose. So that's something which is a given. So if you see, we also need all this with common cold and flu, sore throat, UTI, bronchitis, skin infections. COVID is no difference because we have excess cortisol. And therefore, we ensure that insulin should never be stopped, drink appropriate fluids, and monitor everything appropriately, follow SEB rules. This COVID diabetes front door guidance in United Kingdom, which was come out by the British Association of Clinical Diabetologists, was very useful. That treat diabetes in an emergency response state, particularly for hyperglycemia and diabetic ketoacidosis. So there are two pathways we have. Either give them oral medications. If you can manage them at home, or if there's mild COVID, or if you have home isolated, we can manage most of our diabetics at home very well. But if they get into hospital, we prefer that the OHS be continued if they are eating orally. But if they are moving into an ICU or a critical state with moderate to severe state which needs oxygenation, probably insulin is in the order. So obviously a patient-centered approach is appropriate based on the age, severity of COVID, cardiovascular comorbidities and hypoglycemia risk. And we need to treat them with a euglycemic individualized goal approach. So obviously we need to avoid anti-hypoglycemic agents in hospitals which will cause volume depletion and hypoglycemia. We may need to downgrade the doses of anti-diabetic drugs. We sometimes may need to stop metformin if needed, and that's something which we need in order. So that's why different authorities came with different guidelines. Like there is a strict no-no in hospitals for SGLT2 and metformin. For sulfonylureas and insulin, lot of caution has to be exercised and monitoring for hypoglycemia has to be exercised. And obviously in ordinary cases, subcutaneous insulins are recommended. In severe cases, IV insulin is recommended. Good glycemic control is on order. During the illnesses, glucose will rise. Try to keep it between 110 and 180 and test at least twice a day. So if you test twice a day, what are the red signals in a diabetic? If the glucose goes above 180, increase the dose. If it crosses 250 or 270, which is the ketosis threshold, get them in hospital. If in hospital, get aggressive. Insulin probably has data in animal studies that it reduces the renal ADAM17 expression in diabetic mice, which reduces the urinary ACE2 shedding, increasing the intrarenal ACE2 expression. So obviously in human data, there are no such concerns. Metformin could be anti-COVID. Sulfonylureas are neutral. And pioglitazone can actually down-regulate ADAM17. So there could be an upregulation of ACE2 in insulin-sensitive rats. So all this animal data cannot be applied in day-to-day medicine. Liraglutide has a similar risk. SGLT2 inhibitors actually promote renal ACE2 activity. And gliptins are probably the only agents. You know that DPP4 was the receptor for MERS-CoV-2. DPP4 do not alter the ACE2 activity in diabetic mice. And DPP4 inhibitors might have an anti-COVID role, just like metformin may have. So in early COVID, in early admission, we advise them to manage glucose, take ketones, stop SGLT2 inhibitors, give some fluids, hydrate them. In severe cases, start IV insulin drips. That is the standard of care. And therefore, they have this ABCDE approach in which We look for shortness of breath due to metabolic acidosis, start them on insulin and upgrade immediately. Watch for hypoglycemia and up titrate appropriately. All these guidance is available on the websites, and monitor for ketones and ensure that the inpatient care, stop oral agents, give insulin and monitor them well, manage other comorbidities appropriately. ACE2 agents can be continued and ensure that there is no challenge with them at all. But is there a role for gliptin? Because DPP4 looks like an appropriate treatment approach, because we know DPP has the entry receptors to ACE2 receptors. Is a key receptors during the MERS pandemic. Is a serine protease enzyme itself. It is similar to the viral protease, so it's very mimicking the viral protease. And if we give DPP4 inhibitors, it could be anti-inflammatory and immunomodulatory properties. And in DPP4 in elderly, diabetics, obesity are increased. So there's a lot of retrospective and observational data to suggest that people who have used DPP4 inhibitors and looking at outcomes of COVID-19, and we are also compiling our own data, show some potential benefits. So clearly there is some data showed there is no benefit, no harm. Retrospective data showed decreased mortality. And we have these elegant studies which have been published from various centers, including the multi-center study, which was published in Diabetes Care, which showed that with sitagliptin, actually, there was reduced mortality with type 2 diabetes in a multi-center case control study. We also showed from Italy that gliptins work. And very clearly, we show this from this data in Diabetes Care that if you give DPP4 inhibition in COVID-19 like sitagliptin, it might impact mortality also. And the hazard ratio is 0.13 and 0.44. So they could have some life-saving potential. So probably, is there a mechanism to show that the COVID-19 mortality with sitagliptin treatment might have some high science on it? Yes, it's possible, it is probable, and it's a research area. In India, we have come out with our own Association of Physicians and ICP recommendations for diabetes and obesity. We feel they are risk factors. They are associated with severe disease. They have immune defects. They can cause pancreatic damage as well as stress hypoglycemia. And if you get diabetes, male gender, elderly, hypertension, chronic renal disease, they need strict supervision. Early diabetes specific nutrition is order of the day. Monitor glucose and anti-diabetic agents appropriately, and also take care of cardiovascular health. Don't ignore cardiovascular health. And then the last point is, are we looking for one more wave? Because we are now looking at another wave coming up. And due to this disaster of COVID, we are going to see that you will need communication and consultation. So as physicians, it's our job to consult remotely and communicate with our patients for insulin titration, hypoglycemia and hyperglycemia. We need virtual consultations, and we need to ensure that we need to protect our patients to preserve ourselves. That's the new normal. We need to do mass testing for diabetic patients. We need to do telemedicine. We need to encourage telemedicine more and more appropriately. We need to use apps. We need to ensure that we follow our highest ethics, which is very, very important, so that we maintain confidentiality, privacy, data integrity, informed consent, autonomy. And we need to ensure that we need to have a right setup for appropriate teleconsult. That's so important. We don't need to forget nutrition. Drink adequate amount of water, eat enough amount of vegetables, eat right, eat slowly, eat on time, sleep well. And it's important that nutrition will have more focus, mental health and stress will have more focus. And don't forget vaccinations in our diabetics, because it's important that they need to be protected. They need to get their flu shot, they need to get their pneumococcal vaccine shot. And therefore, it's very important that you don't forget your flu vaccine, pneumococcal vaccine, and various other vaccines for diabetics. And these all recommendations are available in public domain. So I'm very grateful to Dr. G. Vijay Kumar that he allowed me to present COVID in COVID times. Diabetes is clearly a risk factor. And we know that when you get diabetes, you will get severe COVID and you're likely to die. Glucose control is important in COVID times. We need to empower doctors, physicians, healthcare workers to manage diabetes. We need to reach out to our diabetic patients. We need to make an effort. We need to use telemedicine appropriately. We need to protect our diabetics from hospitalizations and COVID. And we need a holistic diabetic care for our diabetic patients. We are all here with a common goal for diabetes care. And I'm happy that COVID care has put diabetes more on spotlight. I only wish and pray that diabetes across the world, including India, will take care of themselves better in COVID, because in COVID, we are all sitting at home, so we have become sedentary. We have been eating inappropriate foods and we are stuck on to screen time. So my only take-home message is for all diabetics is eat less, walk more, sleep well, and do a 2 hours of digital detox every day. I'm really grateful for Dr. Natarajan and Dr. Vijay Kumar for allowing me to speak in this meeting. And I'm thankful that you have allowed me to speak here for what I like to speak on. Thank you so much.
Thank you, Dr. Shashank. Thank you for your extensive talk, and which you have completed in 20 minutes on dot. Thank you so much for that. You extensively dealt the correlation of COVID and diabetes, starting from pathophysiology and moving on to the relationship with the AC inhibitors, the receptor, and the hyperglycemia and the mortality in COVID, and the management step by step, and the treatment pathway and patient-centric approach, and the usage of DPP4 and home approach and telemedicine, and adjusting to the new normal what we are experiencing. Thank you so much, Dr. Shashank. Open for question.
Dr. Shashank, I have a question. So you are in the task force for Maharashtra COVID-19. So you are also mentioning about the second wave of virus. Do you think that there is a reduction in infections nowadays to get a second wave, or you think that it has come down and are going to be a second wave? I feel it is still continuing. That's what I felt. But you're the right person.
Let us look at India is a mini continent, and in India, you are right that in say Mumbai, Maharashtra, or say in Tamil Nadu, we are still getting out of the first wave. So we have had the first peak in Mumbai, for example, in between mid-May to early July. We had the second peak after Ganesha festival between 15th to 30th of September, and we might get post-Diwali a small peak. And our second peak, if it occurs, will occur end December to end January, if it occurs. Remember, India is a tropical country. In a tropical country, usually the peak is during monsoon times. Now, remember that south of India gets second monsoon, which second peak can come with the second monsoon. The point is that in north of India, due to pollution, due to unlocking, due to festivities, and due to low temperatures going below 10 degrees, Delhi had temperature 2 days back at 7 degrees, there has been a peak, which is a second wave. Delhi had 3 waves. So if you look at the geography of Delhi, Haryana, Rajasthan, parts of Uttar Pradesh, Madhya Pradesh, probably they are in the second wave. Let us look back at history. 100 years back, the so-called flu pandemic which came in, which was probably the Spanish flu, though it didn't occur in Spain, but Spain reported it the most. It started from Kansas City and went across the world. India had 15 to 20 million deaths. And that amounts to 1.5 to 2 crores, when Indian population was 22 crores. The second wave was more sinister, more deadly. So what is Delhi seeing? Delhi is seeing a more detrimental pandemic now. They are seeing in their so-called second wave, people without comorbidities between 30 and 60 affected with a little higher mortality. So that is the worry. Now we have to be careful and cautious. We need not be careless and reckless. So I think we have to tread a very careful path in COVID. You are absolutely right that as of now, Tamil Nadu or Maharashtra are reasonably swimming in reasonable waters. But as the temperature will drop down, in those geographies where temperature will come down below 10 degrees, in those geographies where air quality index will go up, we'll have challenges. We are not the world number one. Worst country on air quality is Kabul. Delhi is world number 3. Mumbai is world number 8. Calcutta is world number 15. Unfortunately, fortunately, no South Indian city comes up on the pecking order for pollution or air quality index. So in terms of air quality in Mumbai, we clearly have a challenge. We don't have stubble burning like it is there in Haryana or Punjab, but we do have 2 places where pollution comes from our areas. Number one is vehicular pollution or traffic pollution. And the second area where pollution comes in is from the waste disposal. So we need to have a clean India. That's something which is very important. So that's my take on the second wave. I think,
I have a question.
yeah, Mohan.
Sir, I heard in a talk that you cannot get immunity by suddenly changing your lifestyle. Or walking or exercise may decrease the amount of diabetes, but will it help in building immunity in such a status?
So immunity, which is acquired and innate, cannot be got overnight. You are absolutely right. But if you sleep on time at 10 o'clock, between 10 to 11, you will make some interleukin 10 and interleukin 8, which is protective. So if you sleep for a good 8 hours, your likelihood of getting viral infections is lesser. If you sleep later, you will not make that IL-8. So if you take some simple cues from biology and stay a little healthy, eat a little appropriately, eat a little sensibly, I think we can walk the path. If you are reckless in terms of your lifestyle, if you are digitally intoxicated, you're all the time on a screen, then you are going to actually cause challenges. So it's important that we ingrain some appropriate behavior to build a better immunity. Our immunity we have acquired over years. We have had poorer hygiene, which is why we have better immunity, which is we have a better recovery now. We are BCG vaccinated. Look at Portugal and Spain paradox. Portugal, full country BCG vaccinated. It didn't get the number of cases like the way Spain exploded. So we have some conferment of immunity for sure as Indians. But if we persist with better behavior, we'll have better results. You are muted, Dr. Vijay Kumar. I can't hear you.
Thank you, Dr. Shashank Joshi. Is there any further questions?
Yeah, Dr. Kannan had a question, I think.
Sir, the role of micronutrients, especially say vitamin D, zinc, and the supplementation by exogenous, it is helpful for enhance our innate immunity, sir, as per told, sir.
So these are all adjuvants. Vitamin D levels have been shown that low vitamin D levels in COVID can cause a worse disease. Having an appropriate vitamin D level may help. There have been some studies which have also been done in that direction. Keeping a vitamin D level above 30 or 40 doesn't hurt, but I can't say that it's an anti-COVID therapy. So at best, it's an adjuvant. Vitamin zinc definitely has some antiviral effects, but again, it's an adjuvant. So vitamin C, the data on COVID is poor. So it's not, but in regular cold and flu is better. So in terms of that, I would say all micronutrients should be there in the appropriate doses, but they are not standard of care. Vitamin D and zinc have some data to support it, but not totally in COVID space. Most of the data is retrospective or as old data from respiratory viral infections. And we are trying to correlate it with COVID. Now some COVID data has emerged. So I think give it, but it is just a supportive care. It is not classically a standard of care. Vitamin D probably has some now data in COVID space. So I would still keep it on the pecking order. And we can give a match dose. So if somebody gets COVID, giving 60K 3 doses every day for 3 days doesn't hurt. It's cheaper than doing a vitamin D level. Rajesh had a question.
What is the role of fomites, sir, in transmission? Is it proved or?
So increasingly, the data is emerging that the role of fomites is getting lower and lower.
Okay, sir.
Okay, but it's still there. I don't think you can dismiss it.
Asymptomatic carriers, sir.
Asymptomatic carriers transmission rate has dropped down to 40%. So every asymptomatic carrier may not transmit. So that's only 40%. Also remember our RT-PCR threshold has been, ICMR has put it at 40. We know that infectivity of the particle is only when the viral load drops below the cycle threshold of 24. So any cycle threshold value below 25, the likelihood of infectivity starts dropping down. So that is why if an antigen test is positive, that viral load is higher and the transmissibility is more. If the viral load is lower, the transmissibility is less, but it doesn't mean it's absent. Okay, predominant route of transmission is airborne droplet, not airborne droplet. Crowded spaces, poorly ventilated environments are the key.
Thank you, sir.
Vaccination.
Are you able to hear me, Dr. Shashank? Are you able to hear me?
Yes.
Okay.
Vaccination, Dr. Dharma. Vaccine. We have 5 candidate vaccines likely to come to India. Next month, the first vaccine which will come out will be the Oxford vaccine if the safety is proven. It's the Oxford Serum Institute vaccine which will come out. In 2 to 3 months, we will have Bharat Biotech and Zydus vaccine. The Bharat Biotech vaccine is undergoing phase 3 clinical trials. It's basically a vector-borne vaccine, while Zydus vaccine is a DNA vaccine. The fourth vaccine which will come out is Dr. Reddy's and Sputnik vaccine undergoing phase 3 trials. And the fifth vaccine is a Johnson & Johnson biological events vaccine. Pfizer and Moderna, which are mRNA, which need very high cold storages, are unlikely to come. Right now, the data in public domain is only for efficacy, that too not published. Safety data for even Moderna and Pfizer is not yet out. So we need to see the publication before we speak. Okay, so vaccine will be there, but I think for India to be realistic, it will come in anywhere between March to June of 2021, but full India will only get vaccinated by 2022.
If the chair permits, I'll ask one question. Last question.
Yes, last question.
Dr. Shashank, anyway, we are blessed in Chennai. We have only 3 seasons: hot, hotter, and hottest seasons. So we don't have any cold season. That is one thing. So second thing is that how about your take on that reinfection? You know, a lot of people are worried and scared. What is it you suggest the delegates?
Reinfection is exceptionally rare, but its prevalence in healthcare workers in COVID care is